All right.
Excellent. Well, welcome everybody. I'm excited. We have a lot of content to get through and hopefully a time for some really good discussion and some of the polls you saw last time and some new polls. So that will all be fun. I went down to Olympia today and I'm driving in my car currently and almost home. So I am passing it back over to Jean Marie to carry us forward.
All right. Thanks, Judy. Appreciate it. And also just a short thing, the recording of this meeting will be posted on our webpage afterwards. And you can find the agenda for today under the first tab in the meeting materials, which I'm going to go through here real quick. And just another reiteration, if you're not a committee member, please turn off your camera and your microphone. All righty, so our jam-packed agenda. I'm going to do the roll call since Judy is in transit. And then after that, we're going to vote on the February meeting summary, or I'm sorry, the March meeting summary. I know which month it is. That will be followed by public comments. And then I'm going to review the committee charges that we got from the legislature, which we're going to segment throughout the day in different sections. And then Judy and I will go through the definition that was a proposed amendment to the definition that you all came up with that was approved by the board. We got a letter about that, and you'll have an opportunity to vote yay or nay on the proposed amendment. And then Shane, our colleague from Center for Evidence-Based Policy, Shane Moford, will present on strategic options for collecting and analyzing primary care data. And you all, the committee members, will have the opportunity to provide your feedback on these policies and offer any additional strategies that you want to be considered. Shane is going to be followed up by Gretchen Morley, also from CEBP, and she's going to present some more policy options centered around increasing and sustaining primary care. Similar to the data presentation and discussion, committee members, you'll be able to provide your feedback and suggest additional strategies. And then at the conclusion of the strategy discussion, we're going to pick up where we left off at our last meeting. I swear I can talk today, and lead the committee through discussion and voting on the remaining code service sets. Throughout the process, please feel free to ask questions at appropriate times and provide your feedback to help facilitate our discussion. Thanks for everything that you guys are doing to move this process forward. And I'm going to go ahead and start with roll call now. All right, when I call on you, please unmute your microphone and let us know that you're here, and then please go ahead and unmute when you're done. Crystal.
Hello.
Hello. Sharon.
Sharon Eloranta is here. I know there's another Sharon, but yeah, I'm here.
Okay, great, thanks. Tony.
He might join later.
Okay, perfect, thanks, Judy. I think I did see Michelle.
Yes, good afternoon.
All right, and I saw Nancy, but
I'm here.
Great, thank you. Tracy? No Tracy yet, that's all right. And I know David said he was going to be out. DC? I think he said he might be joining later, so we'll keep tabs. Other Sharon? Not Sharon Eloranta, Sharon
Brown.
Brown, that's right. Yep, there we go. And Greg? No, Greg. Okay. Chandra?
I'm here.
Okay.
And I'm not Sharon Brown. I don't think she's here.
Oh, she's not here. Okay. Thanks for the Thanks, Judy. Appreciate the clarification. Okay. Meg? I think Meg's been having a stand-in the last few times. Anybody standing in for Pacific Source? Maybe not. Cheryl had said she was not coming, so I have that one. Lan?
Hello, I'm here.
Okay. Kevin? No Kevin. Eileen? Katina, I definitely saw you.
Yep, I'm here. I'll be having to jump off early today.
Okay, thanks for letting us know. Mandy?
I'm here.
Thanks, Mandy. Jonathan,
Here.
thank you. Sarah? Okay. Linda?
Here.
Thanks, Linda. Sean?
Here.
Thank you. Stacy, pretty sure I saw you.
Yep, I'm here. Welcome. Thanks.
Thank you. Saw Jenny because we had the chat about the evergreens. And Maddie. Maddie Wiley? No? All righty. Well, we'll keep tabs and see who all joins.
I
So
am
let-
here.
Oh, you are here.
Sorry,
Okay.
one of my mutes was still on.
No, that's all right. Okay, so now we're going to head to the meeting summary, which you can turn to in your meeting materials. And the recording of the last meeting is posted on our webpage. I know we included a reference to that when we sent out our email. Is there any discussion of the meeting summary or proposed changes? Okay.
I move we approve the minutes.
Okay, great. Skipping right to
I-
the motion.
I
Oh,
I have one correction. The end of the minutes says that the next meeting is March 30th, the same day that we had the minutes.
oh,
At
that's
the
a good
very
catch.
end.
Yes,
Yeah.
we will amend that. Apologies for
Great,
that.
no
So,
problem.
Yep, thanks, Maddie.
And then I'll second it with that amendment.
Okay. Any other edits? Any discussion of the proposal? All in favor, say aye.
Aye.
I
Aye.
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 Beautiful. Any opposed? Hearing none, the motion is approved. And now we will begin public comment. So let me just skip to that. Sorry, I'm not used to juggling them both this much. So public comment. When you are called upon, please state your name and affiliation, if any, before speaking. And do not raise your hand more than once, please. This helps to ensure that everyone has a chance to speak. You're also welcome to provide your comments in writing via email at any time. And please remember that this time is reserved for public comments. At other times in the meeting, those are Q&A sessions just reserved for committee members to ask questions. So is there anybody who would like to provide public comment this afternoon? I'm scrolling down my list just to see if I see any hands. Okay, going once, going twice. And we're gonna move it along. All right, and maybe if we have time, if somebody pops in, we might go back, but I'm not hearing anything. We have a lot to get through. So next, we're gonna begin our presentation, and I'm gonna start off by reviewing some of the charges that we were given from the legislature as proposed in SB 5558 or 5589. All right, beautiful. So the way that we laid this out, we decided to chunk it out between the primary care definition, the pieces of the legislative statute centered around data, and then finally ending with policies that would increase and sustain primary care. So each bit of these buckets, the pieces of language come directly from the statute itself. So you have seen that we've gotten through the definition pieces, although we're going to consider a proposed amendment today. We're still in the process of assessing claims-based spending. We haven't gotten to non-claims yet. And we're going to start to dig into these other two categories around barriers for data access, accountability around data, and ways that we might promote reimbursement and incentivize primary care spend. That's the last piece. So, oh, and I should flag, sorry, did we miss the goals slide before this one? We can back up just one hair. There we go. So overarching goals for the day, we're going to finalize the definition of primary care, consider the amendment and vote on that. And then, as I alluded to, we're going to begin the discussion of data, incentives, and payment charges given by the legislature. And just a note around that, like how that's being used, because we do have a report, the board is going to be reporting on our work. This is just laying the groundwork for future steps. So we do not have, as has been talked about at previous meetings, a concrete data strategy yet. It's under development. We are actively working on it and have folks from our data shop that we're meeting with to hash out those details. But what we come up with today, any kind of ideas that get voted on are, for the most part, high level topics that we'd like to pursue and prioritize, that gives us kind of a roadmap to work towards as we plot our course. So that's just how I wanted to set up that framing there. And then, of course, once we get through that meaty discussion, we're going to try to complete as best we can the review of the remaining code sets. So that's your overview of the day. Now we can fast forward through a little bit of whiplash. There we go. Great. Primary care definition. So you guys came up with the definition that's on the screen here. And then we got a letter, next slide, from a couple of members who wanted to basically include the what, or we have the what, but they wanted to include the why. What's the purpose of the definition? And make sure that that's explicitly flagged, especially so that community members, when they're looking at our definition, understand the purpose behind it. So we want to try to amend it, potentially. So in red, I'll just read the sentence that is amended, not the whole thing. Primary care includes a comprehensive array of equitable, evidence-informed services to create and maintain a state of overall health and wellness for each individual through a continuous relationship over time. So the to what end there is the red language that's been added. And it's up to you all to vote on that today, whether or not you consider that a reasonable addition. It's something that was also brought up in board discussion before. So yes, Nancy, you have a comment question.
So I totally agree with Dr. Sananen in the fact that we need a why we're doing this. Yeah, I couldn't remember what or why. Creating and maintaining a state of overall health and wellness sounds like an amazing aspiration. I can't create health in anyone. So I like the idea of adding a why. I'd like to reword it slightly. I'd be happy to propose that.
Okay. Did you have specific language that you?
Yeah, I mean, so I would change it to say, where it starts create, I would add to support patients in working toward their goals of physical, mental, and social health and well-being through a continuous relationship over time.
Just to make it a little less like we are not the authoritative people dictating the outcomes of everyone's health, because we can't.
Yes, and to just, and not to create the illusion that I'm going to create health.
Because you can't. Yeah. But you can help create the supports that will lead to those things.
I can support patients moving towards their goals of health and well-being.
Right. Linda, you had a comment?
Yeah, I was when I was reviewing that, and I thought great to throw that in the why. And of course, we could have probably a whole entire page of things that we could write. But I had put forth the idea of the equitable, evidence-informed services to promote overall health and wellness through illness prevention and minimizing disease burden via continuous relationship over time. Because because I feel like, what are we doing? We're trying to do health promotion and health preventative health strategies. I mean, this is talking about the individual. Of course, we want to expand that and look at primary care in regards to population health, right? But then also the disease burden, whether it be acute or chronic illness, is also what we're really targeting. So that's why I came up with that thought.
And actually, we don't have the chat function, Rats, because I was going to say it's helpful to be able to visualize the written changes. Nancy, did you have comments in response to Linda's proposal, or?
Yeah, I mean, I forgot to lower my hand, but I mean, I do think primary care should be meeting people where they are and supporting people in their goals. So I would prefer that language over promoting health as though we have an agenda. I'll take my hand down.
Linda, anything you wanted to clarify then about that, just around?
I mean, again, I threw
Or
these words
others.
together for them to be kind of wordsmith, but the idea, I understand Nancy's point, and I think that sounds great because it's really a partnership. So it's again, meeting the patient at where they're at. And so, you know, however we massage those words to it, but it is the goal is to maintain their health and wellness at whatever that is, even if it means that they're in a state of chronic disease, right? But yeah.
I see Shane typing in there. Yeah.
I may need some help though, and we'll have to figure
Since
out
he's
which of
got up.
the two paths to walk down. So
Yep. And Lan, you had your hand up too.
Yeah, my comment was similar to what Linda was saying. I think the words to create and maintain puts this ownership only on providers. And I was just thinking of some language where we say in partnership with, or, you know, with our patients, and, you know, leaning towards the, you know, this is a shared decision making, right? And so I think to, you know, that line to create and maintain kind of puts that ownership mostly on providers.
Any other comments on removing the create and maintain? I can kind of see why we would why you all might want to shift that away. Nancy, can you say again what your initial phrasing was? I know it had create and maintain, but if you were to blend it with Linda's.
Sorry, yeah, I'm going in and out because my computer's slow, but I did send it to you in an email just now. So
Oh, you did.
If you want to open it up,
Yeah, that's helpful. Thank you. To support patients in working toward their goals of physical, mental, and social health and well-being.
Just the physical, mental, and social health, that comes from the WHO definition of health.
Yeah. Mental and social health and well-being. Yep. What do other folks think of that wording with the create and maintain eliminated and then the patient support?
So this, Jean Marie, this is Linda again. So again, the other pieces that I threw in there, just to throw it out there again for consideration, is the idea of how we're approaching that, which is not only just a continuous relationship, right? But if we think that that's the only thing that we want to emphasize, I'm okay with that. But I was putting in, you know, through basically the mechanisms are through illness prevention and minimizing disease burden. Is kind of those other thoughts that I put out.
That's right. Thank you for re-emphasizing that. So I don't personally, so yeah, I think the consideration of having all three of those, although it's not up to me, what does the rest of the committee think about having those three pieces, not just the continuity of the relationship? I see your point too, Linda, that it's here are the specific mechanisms, the continuous relationship being only one of them. All right, so I can't propose a motion. Judy, I know you can't see it in front of you, but
yes, I
you
have
ask
liked
someone else
this,
yeah.
I propose a motion to adapt the new definition as put on the screen here.
Okay.
I'll second that.
All right. Any further discussion to the amended language that's on the screen before you all vote? If not, Shane, if you want to go to the vote poll.
I'm so sorry, this is Linda. It kind of, it seems odd to me, like, for each individual through a continuous relationship over time, comma, illness prevention and minimizing disease burden. I think it would make sense to put that in front of the continuous relationship. So the social health and well-being of each individual through illness prevention and minimizing disease burden via a continuous relationship over time.
Gotcha. No, that's a good rearrangement.
I thought the same thing. This is Maddie.
Beautiful. So other folks are on the same track.
Sounds much better.
And also, are we changing before each individual? Are we changing that to of? And well-being of each individual?
I think that would grammatically make more sense. Okay, well, with all of those little tweaks, I think Judy's general motion still stands. Those are just small edits, rearranging. So unless anybody has further discussion of the proposed amended language. Because those were good catches for ordering.
Okay,
If
sorry.
Oh, no, go ahead, Linda. Yeah.
As I read it through, and social health, let's see. Working towards the goals of
Too many
physical, mental, and
ands.
social health. Get rid of it. Does the and make sense in there?
Physical, mental.
Social health.
One of those and should
And-
go. We say physical, mental, so.
I think the and needs to stay, and social health and
And general, I guess.
Well,
you
in
can
general,
vote.
there, thank you.
Yeah,
Thanks,
there you go.
Nancy.
Okay, thanks for
And
catching that.
This is Maddie. I think where we put via, I think I would through sounds better, I think, grammatically. Through
I was
a
just-
continuous.
I was just putting a synonym because I'm like, how many throughs do you have? I'm
That's true.
I'm
Lots of
terrible
throughs
about
and ands.
repeating the same word.
But I do see your point, Maddie. I don't think it's going to kill anyone if we have it twice there.
Right, right.
All right. Any other reordering, word substitutions? It's great. I just want to make sure we've covered it.
Okay, just because I'm a little grammatical, this is Maddie. Why is each individual, it's got the dotted line under it, which usually means something grammatically, but I don't know what.
Yeah, I think it wants you to pluralize it. if I had
Okay,
to
that's fine.
guess.
Yeah, I know how sometimes it'll do that, and that's not necessarily right, so.
Exactly. I would actually leave it as it is.
or you could say each person.
I wonder if it would still flag it, but yeah. Oh, maybe not. Okay, I guess it didn't like individual. All right, so going once, going twice. Any other language substitutions? Are we good to vote? All right, we're going to go back to the poll screen. And Shane, do you want to refresh folks' memory about instructions for joining?
Yeah, absolutely. I know a lot of you have done this before. It's the same drill. There's instructions on the screen here. If you go to pollev.com, it'll pop up a screen where you'll enter CEBP OHSU 925. It will ask for your name, I believe. It would be helpful if you could include that for our documentation of votes. But we'll give everyone just a moment to log in here, and we're essentially just going to warm up our voting skills by checking out this poll. The poll is, I support the proposed amendment to the primary care definition.
This is Katina. I'm not able to log in. I'm on my phone, so that might be part of the problem.
Okay. You also have the option, if you'd like, you can send a text to 22333. And if you put in the body of the text CEBP OHSU 925, that should allow you to vote by phone as well. Are you able to see the screen? I can repeat that if it's helpful.
Yeah, if you can repeat it and I can type as you're.
Yeah, absolutely. So if you text to the phone number 22333, and the body of the text message would be CEBP OHSU 925, and it'll raise some prompts for you.
And Shane,
Thanks.
actually, if you email Serena, and if you don't have her email, I can email it to you, but if you email Serena the instructions, she can put it in the chat for folks to see, because I think she has the ability.
Okay, it's actually at the top of the screen here.
It is, yeah.
I can't open up one more thing. The way I've
Oh,
set-
okay. Nope,
Sorry.
then we're all good. Nope, we're flexing here. It's all right. We're doing okay. Thanks also for doing the active amending to the definition. That was helpful.
Yeah, sure thing.
Sorry, and this is Maddie Wiley. Oh, so I'm trying to text, but it tells me to join first. It doesn't make sense. I went to polleverywhere.com from texting and it didn't give me anything.
Rather, so if you're using the text option, you essentially would just send a text message, like you would to like a friend or someone else, and
Right.
you would text to the number 22333.
I did that, yeah, 22333, and then the CEB POHSU 925.
Yeah, you shouldn't have to put in pollev.com.
It says I've joined Beth Church's session.
Yep, that's perfect. I'm Beth. I'm the honorary Beth Church today.
Okay. and then is it supposed to take me somewhere where I answer the poll, because it's just sitting here in text?
You can try texting the letter A, B, or
Then
C.
you text, you text the letter on.
Oh, okay. For
and
whether
it'll
it's free or not,
say-
sorry. Okay, so just
Right,
text that,
yes.
send that, and then that will click in somehow or other.
Yeah.
Okay. All right, well, I just texted it, so if it increased by 1, then maybe.
Then success.
Do we have, Shane, do we have the screen that shows actively the number of votes?
This does not actually have it. I'm not 100% sure how to pull it up. So,
Okay. Are you able to see the polling results? Whoever is trying to talk, I can't. Judy, was that you or someone else? I don't know. I guess, Shane, I'm just wondering, so, oh, you do. Okay.
Yeah.
Cool. So if you scroll up on that piece.
Oops.
I think it's your little bar to the right. There we go. Oh, it doesn't give a number though. That's interesting.
Yeah. Sorry, on this view, it's not giving it to me. But we are unanimous here on the final definition. And I can pull up the count afterwards here.
Okay.
When we're in
Just
the
to
next-
verify for folks, we're not skewing the numbers for you or anything. But okay, it looks like the motion to propose or to adopt the amended language. Thank you to everybody for fine tuning. That was great. Passes. So sorry, Judy, I might be stealing your thunder by saying that. So
Go right ahead.
okay. All right. All right. So now I'm going to turn it back over to Shane, and he's going to lead the discussion on the data piece within the legislative statute.
All right, folks. So this is, I think, going to be a really, the rest of the meeting is going to be some pretty interesting conversation, because we're going to be introducing different types of policies that get at for this section, the data to support primary care, and then after that, policies to increase and sustain primary care. The way that we're approaching this conversation is we've identified a national source that has gone through a fairly robust process that includes public engagement and research and convening of committees to identify data strategies at the national level for CMS that would generally support ensuring that primary care has the data needed to be effective and the systems in place to use that data. You can see in the right, I won't read it all for you, but the National Academy for Sciences, Engineering, and Medicine, NASEM, the Primary Care Committee, you can see the efforts that they went through to develop these recommendations. On this next slide, you can see some of the objectives for achieving high quality primary care. And I think what you'll see is that these are principles that are generally aligned with some of the same types of goals that you have here in Washington. But the recommendations that they've developed, they serve as a good starting place for thinking about what types of data strategies to make sure are supported in Washington. The data folk that are supporting this project from HCA, they were kind enough to review the NASEM recommendations and to provide some Washington specific context about what's currently happening and then how you might augment those strategies or what you might do with those, some of the things where the groundwork has already been laid in Washington to further bolster the data capabilities, access to data, and the analytics to support effective primary care. The first NASEM recommendation is really around the meaningful exchange of data, ensuring that primary care practices have access to all of the data needed to provide whole person care. The general strategies include leveraging a centralized data warehouse, this concept of individualized health data card, which essentially allows patients to bring some of their data with them so that it's accessible. And then also distributing sources connected by a real-time functional health information exchange. For the Washington context, there are essentially 4 key things already in place where there's opportunity to continue to expand on those efforts that are aligned with this general concept of ensuring that primary care has access to data. There's the clinical data repository, which contains clinical data from electronic health records. And this could be augmented through additional investments and regulation allowing all providers to submit data. There's the Washington All Payer Claims Database, the Washington APCD, which contains claims data for Medicaid, Medicare, and commercial clients. This could be augmented through encouraging self-funded payers to submit data. So essentially ensuring that that data set is comprehensive. There's the Washington Health Information Exchange, the HIE, which is operated by One Health Port. And then this could be augmented through additional investments and directing future state initiatives to leverage the HIE infrastructure. And then lastly, for this subset, there's the Washington Master Person Index. And furthering this strategy could be done through the use of a uniform identifier that facilitates delivery of public services, so reinforcing the use of that. The next set of strategies related to data, these are more focused around, so starting with the NASEM recommendations, they're focused around ensuring that there's accountability for and the technology infrastructure in place largely related to EHRs. The Washington specific contexts, so some options for strategies that build on some of the existing infrastructure here. So you could invest in and support HCA's EHR as a service initiative, which would provide access to certified EHRs for behavioral health, small and rural providers. There's this concept of accountability that's parallel to the NASEM recommendation. So HCA should hold its EHR as a service providers accountable for meeting certification standards with minimal need for local modification. And then lastly, You could invest in and support HCA's electronic consent management initiative, which captures and makes visible clients' consent to share their sensitive health information. So essentially easing the exchange of sensitive health information. So there's a suite of strategies, again, that are getting at ensuring that there's the data infrastructure in place, that the providers have the ability to ingest that data, and accountability mechanisms as well. And then the Washington context is really about reinforcing the infrastructure with investment in future policies. So, sorry, I skipped one more. We have another poll for you here. Jean Marie nicely teed up this concept of what we're doing today is really introducing some concepts along the line of your core responsibilities in this work group. So identifying data policies, identifying policies that sustain and increase primary care. And so for this section, we've given you a little bit of a flavor predicated on some of the recommendations from NASM and how that translates into strategies for Washington. And we're going to use this poll to help lay the foundation for future work. So you should be able to use your existing login that you had. And what that does is it'll allow you to enter this screen, and you can do two things here. So I've pulled over that initial list of recommendations based off of existing efforts in Washington. And so these would be recommendations, your initial recommendations for data measurement or collection and support of primary care. You can upvote things that resonated with you from that list. You can downvote things that didn't resonate with you. And you can also add any item that you feel could support this goal for primary care, but isn't on that list already. And that will allow your peers the opportunity to think about your recommendation and also up or down vote it. We'll give it a minute here to let you read through the options and to engage in voting and to enter your own ideas. And then what we'll do is we will pause the data entry here, and we'll offer you the opportunity to discuss particularly any of the new additions. And then we'll reopen the polling, and you can react based off of that discussion.
And this is Judy. I just wanted to put an even finer point on it. So your responsibility is to give advice to the legislature about ways to increase spending on primary care and that fourth bullet. And so how you do that is through legislative reports that happen annually. And so the first one is coming up, and I didn't want to wait until next year for you guys to have recommendations, because I suspect some of you have recommendations you want already. And so I wanted to try and capture that in some way so that we can include those recommendations in this year's legislative report. So carry on.
Thanks, Judy.
So like I said, we'll give it a minute here to allow you to read through the options, up and down vote. And also importantly, if you want to add something that you think is missing, please feel free to do so. And what you'll see on the screen is that the things that are receiving the most upvotes are floating to the top of the chart. So we're seeing a lot of support at this point for additional investment in the EHR as a service to ensure that behavioral health, small and rural providers have EHR capabilities. Also, with one dissent here, but invest and support HCA's electronic consent management initiative to support exchange of health information. Support for the master patient index. investment in One Health Portal. Also support for encouraging self-funded plans to contribute data to the APCD. I'm not seeing any additions, which is totally fine, but I just want to also verbally ask, looking at this list, are there things that those of you on the committee think might be missing from this list that we might want to consider adding?
This is Chandra Hicks. To what extent is the total medical expense and cost growth target data possibly useful for something like this?
That's a good question. I'm not sure I have a great answer for you, honestly. I think that you have, when you're thinking about how you support primary care with data, I think you have a suite of use cases. The things that we're looking at here for data supports, the ones such as encouraging the self-funded plans to contribute to the APCD, that would obviously have a direct flow through to measurement of primary care expenditure. But I think the majority of the others are actually about improving efficacy of care and reinforcing patient relationships and ensuring that whole person care can be delivered. I think one of the things that you're going to see when we get to the next section is that part of what we're trying to do is take a little bit of a step back and think about not just the total dollars going to primary care as you just need to have direct investment. That's obviously a piece of it, but we're trying to think of it more globally as, well, what are the factors that go into primary care and how do you support primary care and being successful? Because ultimately it's not about just increasing primary care expenditure, it's about getting patient outcomes. And so thinking about data, it's like what things need to be in place to reach the ultimate goal, of which the 12% is one step towards getting there. All right, I am going to temporarily pause the survey here. Is there any discussion about any of these options or any other questions, or would anyone like to raise anything that might potentially be missing?
This is Maddie. The uniform, having another ID just really is like, oh boy, theft, identity theft, and all that kind of stuff. I would be very concerned about that.
Mm-hmm. Other thoughts or comments? It looks like our top voted item here really is about investing in support for, again, the EHR as a service initiative, which would help ensure that there's EHR infrastructure for behavioral health small and rural providers in place.
Mandy, did I see? Oh, now I see Linda, but Mandy, I thought I saw your hand up briefly.
Yeah, we don't have anything in here about expanding workforce. So we don't have anything regarding the workforce itself for primary care.
That is a great point. Our next section, we're going to transition into policies outside of data. And I think you're going to see explicitly there that we tap into that workforce conversation.
Right.
So thanks for the tee up on that when we get there. All right, well, hopefully that was useful to see what some of the NASEM recommendations were, and then subsequently how that translates into what you have going on in Washington, and then being able to rank those so that we have, again, just kind of paving the groundwork for the future work that we'll be doing together, and having an initial prioritization and some concepts to build on going forward. So thanks. Oh, yes, please.
Sorry, I just saw Linda's hand. So did you have a comment, Linda, that you wanted to add before we move to the next one?
Yeah, I just wanted to say one thing about the EHR. So as far as investing in the EHR for BH small and rural, excellent. But I think we also have to look at who actually would be providing the ability for connectivity for the transfer of data, because there's one thing to have a system, but it's another one to be able to provide that feed, which when you have to build that, and I'm so not technologically savvy, but when you have to build that, technical bridge, that actually is quite problematic based on my limited experience. So we'd have to make sure that there's some sort of way that we look at the responsibility, who holds that responsibility, because that can suck different funding dry, I think.
Thanks for that, Linda. I think that's an important point. Any additional comments? Hearing none, Shane, I'll give it back to you. Sorry to cut in there.
No, thanks very much. All right, so I'm actually going to, we were going to originally reopen this up, but we didn't have any additions of policy to discuss. So we're going to go ahead and move on to the next topic. Here we're going to be talking about policies to increase and sustain primary care, and I am going to hand the reins over to Gretchen Morley.
Hi, everyone. I know some of you, I'm Gretchen Morley, also with the center team. I'm going to carry on after Shane here, as he said. We're going to move into that third block of committee charges from the legislation, and those, as he said, are very specifically focused on the strategies to work toward the 12% expenditure target. So I'm going to do the same thing. I'm going to go through sort of a rubric of various aspects, various strategies at a very high level. I think a lot of them are going to be ones that you at least notionally have heard of, and some of you may know quite a bit about some of them. So as I'm going through these slides, I think I have about 7 or 8 of them. If you could be jotting down anything that you're thinking, yeah, that resonates with me, definitely that kind of thing. And then we're going to do the same kind of polling again at the end, where you can respond to some pre-populated ones that draw from the slides, as well as add anything that you think is missing for everybody to respond to. Same kind of up, thumbs down approach that you just did. So, okay, so let's start here with our overall visual slide. What we did here in this framing is trying to demonstrate sort of the multifaceted approach that really goes into determining what the percent of primary care spend is, right? So there's the direct investment, which people tend to talk a lot about. There's capacity growth, which to the member who just raised workforce investment, we have that in that quadrant, as well as reducing barriers to spending time on patient care. We then have patient behaviors. We sort of move around the circle here in terms of their use of primary care services. And then sort of what really is kind of a part of the math of this, in the sense that reducing expenditures on other services, but through sort of that investment in primary care. So this is really just kind of to start on the same page, that we're looking at this holistically, and sort of the various levers and dynamics that go into what ultimately turns into that percentage of spend. So if we can go to the first, so we're going to break down, we're going to go through each one of these little pie pieces at a very, very high level. And the way we have these slides set up is we have some examples of the key actors and the primary levers. So the first one being direct investment. So we have some examples here on the left in Oregon, and Oregon, which has a very specific sort of primary care spend process until they reach 12%. Oklahoma requiring managed care entities to report on primary care expenditures and increasing those expenditures to a minimum of 11% within a time frame, 4 years. From other states, examples in Washington as well, there is also the sort of conversation that is either periodic or regular about sort of changes in Medicaid investment on primary care. So So these are all pretty straightforward examples that I think you all would be, be familiar with. We can go to the next slide. And Shane, I'm happy if I go through any slide too fast and there's something that you want to draw out, just let me know or jump in.
Will do. Thanks.
So the second one is capacity growth. And this is where you're going to see things like the physician loan forgiveness programs, efforts to reduce burden, multi-state adoption of telehealth and the compensability of that service that took rise during the pandemic. Initiatives to support community colleges and their ability to continue sort of education and for nursing and other professionals, particularly in service areas where that's needed more. And then, we would put the Washington primary care transformation model as, a model that really is trying to bring together, quite a bit of aspects of provider supports and payment models and alignment to increase capacity. So we go to the next slide. We did sprinkle in a couple more NASM strategies, just to kind of round out sort of the kind of things being, put in front of you. NASM had recommendations on moving from a multi-payer movement from fee-for-service for primary care toward hybrid models that have some level of, some part of fee-for-service, some level of capitation, partial capitation, and making those really kind of the default reimbursement method for primary care teams over time. And then also that states should use authority to facilitate multi-payer collaboration on payment and fee schedules. To put some of that in Washington context, I think a lot of you are aware of this. There's been a lot of support for value-based purchasing, and payers and purchasers have a variety of payment models right now. And then there's sort of still movement to keep moving that forward in Washington. And then that second bullet on the Washington side, we do have a collaborative structure that has been operating for a couple of years with payers and now purchasers, and reaching out to providers about collaborating on the development of a primary care model that includes the payment models and supports, with the real goal of trying to align payer efforts to reduce administrative burden and create some consistent expectations of practices. So that's a little bit more on the capacity side. We also have, do you want me to do, and this is also, they had recommendations about workforce, particularly diversifying the primary care workforce, really trying to expand the type of providers that are available, and really, supporting sort of the training and loan forgiveness, that kind of thing, of the economic incentives to really support workforce. And then that last bullet is on supporting training in community-based primary care practice environments. So these were also some additional NASM strategies. Okay, and then we're moving around the wheel. We're coming over onto patient behavior. There's a number of examples on this slide about financial incentives and rewards for preventive care, management of chronic disease. You see there in New Hampshire and Massachusetts, incentives for members to have a minimum of one PCP visit a year. There's a history of insurance carriers partnering with wellness and community organizations to really support patients' efforts to keep healthy. And there's an example here in Oregon of educational campaigns targeting the support by respiratory therapists to implement asthma action plans. So that's kind of hitting support for patient behavior and wellness in sort of a number of different ways. And then we're coming around, NASM, we have some NASM strategies. Really that they were recommending aspects of reinforcing that patient-physician relationship. Requesting individuals to and really supporting them in their decision to select a usual source of primary care. and, assigning non-responding enrollees using established methods, and being able to track that information and really be able to use it for payment and accountability measures. And then there was a idea in the NASM strategies about practices and other providers assuming and then documenting ongoing care relationship with uninsured folks that they regularly treat. So those were some additional ideas that they had. And then this is less a recommendation, but more, as we said earlier, kind of rounding out the pie in the sense that, there will be this factoring in of other service categories as you invest and expand primary care. And you see there in the first bullet, these are all things that you have seen before, I'm sure, in terms of evidence around investing in primary care and then having that resulting reduction in more expensive and avoidable services and costs. And then, as you know, this is the math equation in terms of, there's sort of a contribution to both the denominator and numerator, and 1% investment on the primary care side could have even a greater impact than that 1%. As sort of the impact on health and wellness sort of filter through the system. So there you go. So that was a lot. I know we just threw a whole bunch at you. The nice thing is we did pre-populate the poll like we had before to sort of help jog your memory of everything I just threw into you, and hopefully you were taking some notes. So I totally encourage you now to go through these options and do your thumbs up, thumbs down. And then if there's anything missing that you really want, that you want to add, please do. This is a really large bucket of opportunities and strategies. So please don't be shy about putting down any ideas you have that are not here.
Hey, it's Cheryl Marla. Can I make a comment?
Sure. While people are voting, did you get?
Yeah. Well, just real quick, just on the last, actually points that you made there. I'm a pediatrician. It does look very different for pediatrics than it does for an adult population. That you don't get the same reduction in emergency department testing, hospitalization, pharmacy, because we're not spending in all of those areas at a rate anywhere equal to on the adult side. So this does look really different for peds than it does for adults. And we just need to keep that in mind when we're thinking about then what we would recommend, because it's not the same.
Right. And also your comment highlights it further highlights the idea that it's not just a one number calculation. I mean, there's a dynamic aspect to how we look at it, and that can vary by population. It can vary by intensity level. So thank you, Cheryl. It's a good flag for folks to keep in mind. Okay, everybody getting a chance to vote? It looks like we've got a little dance going back and forth between payers reducing administrative burden and costs for providers and direct investment. There's a tie right now with then capacity growth, state-funded expansion of loan forgiveness opportunities. And let's see, Shane, if we can scroll down a little bit just to see what else is. So we've have patient engagement, encouraging employers to support patients in selecting a PCP. That's right behind all those other three. Capacity growth. The MPC, or well, what we call the MPC, the multi-payer collaboration to develop and implement payment models. Okay. Capacity growth, work with education system to bolster pipeline of healthcare professionals.
Hi, this is Sharon. I'm just like, I guess I missed it as we rapidly went to poll, and it takes me a few minutes even to get out there, but I had a couple of things, and I'm not filling out the poll for a number of reasons. One is, I feel like when we showed that very first slide about how we're going to get to the 12%, I feel like we have to do the math part because we can't manufacture 12% out of nothing, right? So if primary care goes up from, let's say, 4 to 5% up to 12%, then somebody else is some other service or activity is giving money back. So it feels like that's not optional, and it's something that it just doesn't make sense. I mean, it's there, but I didn't agree with it. I also feel like when we talk about a hybrid, moving toward a hybrid system, it pretty much can't work within a single practice to have some contracts that are reimbursed via PMPM and some that are still productivity based, because the productivity based ones will take over basically. I mean, you have to turn the number of patients and you lose that part. So one thing that I did not see on here as a suggestion is requirement on the part of health plans that are the health plans would need to require designation of a primary care provider for each member as a potential lever to get that attachment or that attribution to happen. So those are kind of things I thought of, and I don't know that I can vote. I'll go out there and try and vote.
And I know, let's see, the one that comes really close, Shane, if you right there is, we use it, there's a mix of words here, so they could, you can swap in your word there, is patient engagement, encourage employers to support, incentivize, encourage patients in selecting a PCP. So use the word require.
I'm saying require, yeah, because it's more on the part of the health plan. Yeah, employers should do that as well, but it ends up being the plan that holds the reins on that, unless there's some of you all on this line from health plans that can correct me.
I know employers hold a big, employers have a lot of influence on that.
Yeah, they do have influence, but I mean,
they're buying the product.
Mm-hmm. And so they could say to the health plan, we don't enroll anybody without them choosing a PCP, or, you have 6 months to choose one, some sort of leverage there anyway. Okay. Helps.
I was going to say, is everybody aware that Oregon has a bill now requiring plans to assign a PCP? So we're reviewing that right now, but it does pose challenges because the employers want open access. So, that's where the bulk of our commercial membership is an open access plan. So we would love to move people to have a designated PCP, but it's getting the population, the members to want it, the employees to accept that as well.
Okay. Other comments? It looks like we've had a little bit of movement. We have 11 thumbs up now on and we have 12 actually. Thank you, Shane. 12 on increasing primary care reimbursement, 11 on payers focusing on reducing burden and costs for providers, 10 on encouraging employers to incentivize patients selecting a PCP. Loan forgiveness program expansion comes in right below that, as well as working with the educational system to bolster the healthcare professional training pipeline. Any additional thoughts?
I'll also say there's 3 more that people have added, and so you might have to expand or check it out if you haven't voted on those ones.
Thanks for the flag, Judy. Yes, definitely take a look at those. We still have it open, so you can put your input there. Great, thank you for those who added items.
And it looks like Gretchen Jonathan has a comment.
Yes, Jonathan.
Hi, yes. Some of the things that were listed made me think of a couple of things. So one of the things I upvoted was increasing reimbursement for primary care services. What I also specifically had in mind, this would require legislative action, I believe, but specifically bolstering Medicaid reimbursement so that there was greater parity between Medicaid and other payers. I think that would support primary care, but also equity in primary care services. And I think not being a pediatrician, I don't want to speak for what I don't have as much experience in, but I think it would go a long way in improving access to care for pediatrics, or at least supporting pediatrics as a field, since they disproportionately take care of Medicaid patients. And then for encouraging employers to incentivize seeing a primary care provider, one thing that came to mind is, at least anecdotally, I've seen patients who sort of get that financial incentive for seeing me And it's not always been the most meaningful interaction. It's sort of been I've seen the primary care provider once, check the box and never see them again. But perhaps encouraging financial incentives for receiving USPSTF grade A and grade B recommended preventive services might be another way to engage patients in receiving evidence-based primary care services. And then specifically for training primary care practitioners, one thing that came to mind was supporting teaching health center residencies in rural areas of the state. And then lastly, when we were thinking about loan forgiveness, another thing that came to mind was the prevalence of non-compete clauses in contracts and the financial penalties that a lot of primary care providers face for breaking non-compete clauses, to the point where some of them, when they choose to leave a position, end up leaving the state because of the financial penalties of practicing primary care elsewhere in the state. So those were just a few things that came to mind when looking at what was already listed.
Great, thanks. Thank you, Jonathan. Any comments on Jonathan's? You hit on a number of areas there. So any follow-up comments from other committee members?
I want to second the non-compete thing. We got to get rid of the non-competes for doctors. It really does. I find it burdensome. I know many of my colleagues do.
And I agree on increasing, this is Maddie Wiley, increasing the Medicaid reimbursement, because that is a real problem.
Okay.
Can I ask a quick question?
Do we
Sorry.
want to add those as options that people can vote on? Because this is how we're going to capture it in the ledge report.
Yeah, so please do, if, I don't know, Jonathan, you can go in and add, or.
Well, also, I do, yeah, that would be great if you could, but as a backup, I do take detailed notes on all of these meetings, although as some have caught, sometimes I repeat dates. So, but I do mark those down, so it would get incorporated, but I appreciate adding it to this. It makes my job easier. Jonathan, did you have additional comments to make? And Sharon, did you have additional, or did you guys just leave your hands?
I actually have another quick, is that basically a question where we talk about increasing reimbursement for primary care services, which is a great idea. My question is that right now, the costs of those, of all essentially outpatient services, vary pretty widely depending on whether or not you're attaching a facility fee to it. So say you're going to a primary care office that's affiliated with a hospital or a health system, the total cost of that visit is quite a bit more because of the facility fee issue. And so how is that overall going to be calculated so we're not doubly rewarding places that are already upcharging?
Okay, thank you for that. Okay, did everybody take a look at the new ones that were added? I'm going to give you another minute to make sure you've got your votes in.
Hey, sorry, this is Katina. I haven't figured out how to upvote or downvote via the text in Pull Everywhere.
Shane, do you know if that's an option?
I think it may not actually be an option on text, given how the instructions changed at the top.
Oh, you're right. Mm-hmm.
If there are any that you feel strongly about, feel free to let us know. We'll capture that though.
The reimbursement for Medicaid.
Okay.
Yeah, phone people, you could also send an email of the ones that you would like to be upvoted.
Yeah, that would be great for tracking purposes.
Great. Okay. Well, thank you so much for sort of hanging in the whirlwind ideas and for offering ones on top of it. That's fantastic. Do we want to go back up to the top, Shane, just to do a final, if you want to lock, I don't know if it's locked at this point. Yeah, there you go. So direct investment had 13, and then the administrative burden, really, payers working to address that, reduce that, is second with 11. And interesting, the forgiveness on non-compete cause penalties incurred by primary care physicians who leave a position to work elsewhere in the state got 9. So that was one that was added and then voted on. So that's great. And then the patient engagement one in terms of selecting a PCP was right behind that. So great. Okay. Any final comments on that before we turn it? I think it's going to go back to you, Shane. Or Judy.
No, thanks.
Great. Thanks, everybody.
Actually putting Judy in the hot seat on this one. So.
That's right. Judy gets to lead for the last piece.
Okie doke. So yes, so we have done the definition. And so now we are going to focus on that second charge we have of the measurement methodology for claims-based primary care. And so I think we are going to go through the additional services. We are going to we're going to do a similar method to what we did last time. And so I will formally move to accept the grouping on the page, and then we can discuss the set and make amendments, and then we'll move to a poll to say yes or no for the group. I think, is that all I was supposed to say, Shane?
Yep, just a refresher. So it'll be the same process as last time. We just want to note that if you feel strongly about the list and you want to make amendments, feel free to do so, and we'll do that before going to the poll.
Yep. We did have this clarification around domiciliary services because I believe somebody asked for that last time. Yep.
I forgot about that slide. So yes. So the domiciliary services, as you can see, include places like assisted living facilities or group homes. And this is where we're going to start. So I make a motion to include all of these codes on this slide for domiciliary rest home or custodial care services. Is there, and I forgot to say, we are going to do a data analysis as mentioned previously, so that if there are things that are not well used here, we'll have a second chance to come around. But is there a second for that motion?
Maddie Wiley, I can second it.
And then is there any discussion? Okay, then I guess let's vote.
I see the votes are underway. And if I counted correctly, there were about 15 folks earlier, maybe 16 because Cheryl, you joined. So we're just looking for over half, but we should give time.
This is Tony. On the text, do we do A for yes and B for no?
That's right. think that might be everybody, because I know we sort of swapped. I think some folks had to leave early. So I think we can lock it, Shane. All right, looks like it passed. On to the next category, Judy.
Yes, let's go. Nice job, folks. So this next one is about prolonged services.
Oh,
yes, I muted myself. Yes. The recommendation is to adopt all the codes in this group, and these are add-ons to things that happen already. So would anyone like to make a motion?
So moved.
And is there any discussion? Oh, second. Sorry.
Sorry, I just have a comment. I think I just saw in 23 that a lot of these were deleted and they've got a new code 99417, I believe. I mean, these would still be relevant for, looking at past data, but just want to make sure that we capture the new one going forward.
That's a good flag, Michelle. We could definitely, if we vote on this, yeah, my suggestion would be for historical previous data, we keep these, but then whatever the new one is, we'd incorporate that for whenever it was first instated, if it's synonymous.
Yeah,
Judy, that makes sense. I think that makes sense. Any other discussion? Otherwise, Judy, you want to carry us to the vote?
Yes. So let's vote. Okay, I think that's probably everybody.
All right, it looks like this one passes. Let's keep trucking.
Judy, did you have any comments on this slide before you call for anything?
Yes, so this next slide is lab testing and supplies, and the recommendation is to exclude all of these from the primary care spend. I think it to sort this out in which of these, because they happen in a lot of different places, not just primary care. So I move to exclude this list of codes. Is there a second and/or discussion?
Yeah,
John
Cheryl.
Stala, second.
Oh, okay. I was going to second too, so I guess you can have it.
Jinx.
Okay, great. Vote away.
It looks like movement stopped here. I'm gonna lock it down. It looks like this one passes as well. And next up is part 2.
Maddie Wiley, I'll move that we accept these.
Thanks. I somehow got disconnected from this. So this is more lab testing and supplies, and it is also recommended to exclude them for similar reasons as the last. And so is there a motion? Oh no, I'm making the motion. We tried to make this fast, and I'm forgetting. I move we exclude these from the primary care spend list.
And I'll second.
Is there any discussion? Yes, let's vote.
All right, it looks like voting is stopped. We definitely have a majority here, so I'll lock it down and let's keep going.
And I know we want to keep moving, but is anybody having any difficulty? Because I was trying to tally. It looks like there's 15 or so folks and we keep dropping off about 3. I just want to make sure. Is anybody not voting who wanted to vote or is having any issues?
I am Jean Marie, but that's okay.
Okay, all right.
One.
Okay, moving on. Sorry, just wanted to cover our bases.
That's okay. I can't speak for the others.
All right, Judy, any comments on? Oh, you came in. Yeah.
Yes, I don't know if you can hear me.
We can.
Time.
Yeah, it cuts in and out, Judy.
Well, to keep things rolling, why don't we take it over while you're resolving that? Here, this grouping is for temporary codes. There's actually a fair chunk of them, so it's broken into parts. For this particular set, the recommendation for all of them is to include.
And I know Judy would offer to make a motion. Does someone want to make a motion?
I'll make a motion to pass or whatever, where.
Any seconds?
Second.
Okay, any discussion?
EKG.
And one of you, your mic might be on, and I don't think you might intend it to be, just letting you know. Thanks. Okay. I'm gonna propose, well, I can't, but in lieu of Judy. Oh, Linda, you had a comment, Linda.
Sorry, I just slow on clicking. I guess with that EKG, are we taking the same approach when we look at the laboratory diagnostic piece? In other words, is that important to have as an inclusive piece or opposed to or exclude that on that set? I'm just wondering that because as that represents very different from the rest of that list. And then as we go forward, I looked earlier at the slides, but I can't remember all the rest of them, but I know there's further diagnostic tests, let's say.
Yeah, this is a place where I feel less strongly about, yes, we should include the whole list, or no, we shouldn't. So please feel free to have a discussion.
And I am going to back up one step here. You'll have the ability to change your vote if you need to after the discussion. Sorry for advancing so quickly.
Yeah, this is Sharon. I agree that that one stands out for me. EKG for initial, I guess it's preventive exam. That's probably also kind of low value care. If somebody doesn't have any symptoms, just to get an EKG. And it, again, more what Linda was saying, that it falls into that category of kind of you're doing some sort of a test.
And this is Maddie Wiley. I recognize that code. It goes along with when you're doing that welcome to Medicare, and you can offer an EKG during the initial preventive exam. So it's really not, I don't think it's pertinent, but.
Can we vote to approve all of them except for that one on this sheet?
You can. So I hear you proposing an amendment. So would somebody like to rephrase that as a motion, since I can't do that?
So moved. This is Crystal.
All right, so then just to clarify, you guys are voting on the amended version, which would be to include the EKG, or sorry, not to include the EKG, my apologies, and include everything else. Did I hear a second after Crystal initially proposed?
I'll second that, Maddie Wiley.
All right, any discussion? Okay, you guys take it to a vote.
And if you want to change your vote based off of the amendment, please feel free to do so. All right, looks like voting has stopped. I'm going to lock it down, and that passes as amended. The next set here, additionally, it's the temporary codes, but part 2. Here, the recommendation is to include. I would note that this, I think it was Charlotte that had mentioned there is a continuation of EKG codes, so maybe worth discussing.
Yes, this one, it also is included the same thing as the last one of like, oh, I don't know that we have to include all of them. So, yes.
Like those first couple of, well, there are 4.
Sort of spread out throughout. Yeah, yes.
So did anybody want to make a motion and or amend the current set of codes? I guess make a motion to amend. Is anybody wanting to do that?
Can I ask a question, Maddie Wiley? What is the PPS initial visit? Does anybody know what all those P's mean?
That's a good question.
I didn't know what that meant either, so I just Googled it. It's establishment of an individual's medical/family history, establish a list of current providers. It's like an annual wellness visit.
Okay, yeah, so those are all those extra codes at the annual wellness visit that get added on. I don't know what they do with them though. They don't actually have a charge that goes with them. They're just, they're counting points for, did you do these things during your annual exam? So
it looks like they're both on there twice on this current page as well. GO439.
That is right.
They might be initial. They might be initial. There's 3 categories of Medicare. Initial. There's the initial one. Then there's the first annual, and then there's every annual after that. So there's 3 different groups, and that's my guess as to what it's referring to.
Yeah, yeah. The list is.
But it is also on there twice.
Yeah.
I was just noticing that. Yep.
Although I do think that if they don't have a reimbursement with them, then maybe they're not worth including.
Although they do appear to be highly prevalent in other definitions, for what it's worth.
But this is Michelle, I would say that those typically don't have a reimbursement associated with it. That's correct. It's more informational.
Oh, well then, given the purpose of this group, yeah. So am I here, let me just see if I'm hearing correctly. Am I hearing an amendment to take out the PPPS code in its 4 iterations? And also, did anybody have any comments on the EKGs for this one that show up?
I would take everything out. It's all
Yeah,
related to
I
that
would.
initial exam. So
I agree.
On this page, I think I'd only keep the brief alcohol misuse and the depression screen. Oh, and yes, because the alcohol and the depression are also, I think, copied, but the words aren't the same.
Okay, so you would propose keeping those 2, but pitching everything else. Anybody have comments on that? Linda and Crystal, you have your hands raised.
Yeah, so my comment is one, yeah, ditch the EKG stuff. But just because something may not be paid for, there are certain things I think are really important that we track or at least have the capacity of looking at if for utilization purposes, because at some point in time that might be important. And so that would be where that I would say for sure, like the alcohol, the depression, all that. So in the future, if there is something, even though it's not paid, because gosh knows there's a lot of things we could put codes in, it doesn't get paid, but it might be important for tracking later.
Yeah, and this is Crystal. As an FQHC, we do use the, I think it's just PPS. Probably there's probably an extra P there. So we do build that as an FQHC. So I agree, I would keep it in and agree taking the EKGs out or do a little more research on the PPS codes before we remove them.
I agree with that. Those would probably be reimbursable. The PPS, initial visit, subsequent visit. The rest are usually kind of included in the visit.
So actually then what I'm really hearing is just take the EKG and leave everything else. That's what I'm hearing now. That accurate?
So moved.
Okay, thanks, Crystal. Any second to that one?
Second, this is Michelle Cosley.
Any further discussion? Okay, well, let's move to a vote then.
Okay, and looks like voting is led to a stop here. I'll lock that down and that passes as proposed.
Great.
Part 3.
Yeah, so this one is another mishmash of different things, and you can see there are some recommended to include and some recommended to exclude. So I make a motion to include and exclude as stated on the slide. Is there a second and then discussion?
This is Ginny. I second.
Any additional discussion or move to a vote? All right, let's move to a vote.
Like activity stopped. I'll lock it down. Oh, one more. Got in right below or right beneath the buzzer. All right, well, that passes. The next set, looking at supervision.
So these are 5 different codes, and you can see that we recommend to include the first 3 and exclude the last 2. I think because I think because the nursing facility, that's not always primary care, whereas the other 2 are. So I make that motion. Is there a second to discussion?
I will second it, Maddie Wiley.
I'd like to get a little perspective on including the hospice. Do we consider that primary care?
It's a good question. I think you could make an argument either way, especially as hospice and palliative medicine has become more of a specialty in some spots.
What do the clinicians think? Primary care clinicians? Anybody have an opinion?
You know, this is Nancy Connolly. I tend to think of it as primary care, depending on, of course, who's providing it. That would be my bias.
And this is Maddie Wiley, primary care. I would agree. Plus, we also previously said home visits were part of primary care, and this is really just an extension of that, but the person is dying.
This is Tony. I agree. This is Tony. I agree as well.
I will add the caveat here that we probably won't be able to tell a primary care person or someone trained in hospice and palliative medicine, since that's now a specialty, because not one changes their coding based on that. So this may be a year one to sort out.
It's really hard to understand you, Judy.
I think we lost her.
I had one other comment.
Yeah, John.
I think if I remember correctly, we're looking at the intersection of the what, the who, and the where. I'm definitely in agreement with the what and the who of hospice. The one thing is the where, because if you know, one could have hospice at home in a skilled nursing facility or inpatient hospice. And I would certainly think of hospice being primary care if it's home hospice and perhaps in a skilled nursing facility. But I would think inpatient hospice might less so be primary care. And so if my understanding is correct, that the way that this is operationalized is when the what, the who, and the where are all intersected to be primary care, I'm on board. But if it included inpatient hospice, I might not agree that it's primary care.
Wouldn't those codes be different though if it's inpatient?
Yeah, you're right. Inpatient.
The billing codes, yeah.
Yeah, although the professional would. You know, there'd still be a professional, there'd be a facility fee, you know, facility claim, but then the professional would still bill. But I don't know, it might be, I don't know if there's separate inpatient hospice codes. I'd have to look that up. But there should be a site of service, there should be a place of service. So, you know, we could exclude place of service inpatient from the professional claim. You could do it that way.
Would anyone like to make a recommendation and move that?
I move to include what's listed as included with the exception of if hospice is inpatient hospice and to exclude what is listed as excluded.
I'll second that.
Is there any additional discussion?
Thanks, Shane. Okay, I think y'all are ready to vote on it.
Haven't seen activity in a bit. I will lock it down, and that is approved as proposed. I'm not sure if Judy's back, so let me tee
I
it
am
up.
back and I
Okay.
should be here and solid. And I won't move from the spot. So this is a list of cardiac and some pulmonary things. And you can see the prevalence is near zero and that it is recommended to exclude all of these. And I think it'll be hard to tell, particularly for a lot of these between specialists and not. So so I make a motion to exclude all of these. Is there a second and discussion?
I would
I'll
be happy
second.
to second.
Okay, I think maybe let's move to a vote. I think that's everybody. So next. So this is a bunch of derm things. While primary care can do these, so do others. And as a reminder, this does not impact reimbursement at all. Like primary care would still get reimbursed for doing these things. This is not prevalent in other definitions, and the recommendation is to exclude. So I move we exclude these codes. Is there a second and discussion?
This is Michelle. I will second.
Judy, just to clarify, would this, if we're trying to get to 12%, would it impact reimbursement in terms of any proposed increases?
This is Sharon for what it's worth, and I agree with that question. Also, I don't know the answer, but a lot of times these procedure codes are more revenue generating than, you know, service, other types of service. And these look like things that could very possibly happen in a primary care setting.
This is Shane. We may have lost Judy. I think the answer to that is it depends. I think when you get to when it's time to make recommendations on reimbursement policy, you may actually target a limited set with different types of increases. So for example, previously it was mentioned the A and B task force recommendations. Maybe there's a significant increase to those, and other codes that are maybe less prevalent aren't touched. I think that the policy design could vary. That said, if the universal landscape is incentivizing payers and purchasers to move towards 12%, if it's not included, that could have an intersection with the policy as you're suggesting.
Yes, I'd agree with that. And yeah, I think it could also, because some of these are revenue generating, it could increase the amount of primary care spend, and it would end up including, because of our issues, particularly I think with physician assistants, that we wouldn't be able to tell who is it that are doing these services. So it might artificially increase the 12%.
This is Maddie Wiley, and I've been in primary care, and I would agree. We want our money for primary care to go for all the primary care stuff. This is all extra additional stuff.
Is there more discussion or thoughts about this, or shall we move to voting?
This is Ginny, and I make a motion to exclude this group.
Second.
Okay, let's go vote.
And just to flag for you all, I think I counted 5 categories after this, so we might get 2 more if we're ambitious, and then be able to do the next few at the next meeting. Unless, Judy, you have a different vision.
That sounds fine. Although, can we do 3? I don't
Yeah, that
remember
would
what
be,
they are.
I think it's other parts 1 and 2, newborn services and obstetric. So
some of those might take a little while.
yeah, I think people are going to have feelings. So
okay, let's move on to the next one. Oh, but newborn is next. So these are newborn care services for E&M codes of the newborn at the hospital and outside the hospital, and birthing resuscitation. So you can see that only 25% of other state definitions have this in it, and our recommendation is to exclude. I will make a motion to exclude these codes. Is there a second and any discussion?
I have a point of discussion. For 99461, initial evaluation and management of newborn outside of hospital, is that essentially a first newborn visit? Because if so, I would recommend including that one, but okay with excluding the remainder.
This is Maddie Wiley. I saw this before. I asked my billing office manager, and she said that is not the code that we usually use in outpatient for that first visit of seeing a newborn in our office, for what that's worth.
Yeah, that at home? Isn't that home?
That's for home births. Yeah, yes, Cheryl. That's for like right fresh out.
Yep.
Figuring out your APGAR, all of those things. So yes.
In that case, I withdraw my motion to include that one, and I have no further discussion.
I'm happy to provide a second.
There we go.
Any other discussion? We're moving to voting. Let's go.
Just being efficient.
Yes. I think that's everybody now. Oh, and one more. Woohoo, somebody came back.
Yeah, that's all right.
So this part we might need some discussion on, but I'll tee it up. So this is obstetric. And so these codes are all prepartum, postpartum, delivery, all of the stuff around pregnancy. You can see that depending on the code, there is some difference. A couple of codes are in a third of other people's definition, but not all. And I think there are some states that actually have a percentage of some of these codes put in. I know that Oregon is like that, to try and get a sense of, is it a family medicine provider, or is it an OB, and what that looks like. But our recommendation is to exclude all of these codes. And so I make a motion to exclude. And is there a second or more discussion?
This is Crystal, I second.
Any additional discussion?
It is fine if we don't.
You're hearing none.
Yes. A couple more votes trickling in, maybe. We will end it after this. I think we don't have time. And for those of you that have 4 o'clock meetings, we will get you on your way or get you out to the sunshine.
And also, Judy, I am noting, I mean, so 13 has been kind of the threshold, especially because that's the half the number of people at the committee. So if we don't have,
if we
at
don't
least
get
that,
13, then we'll have to bring this back to the next one.
Yeah,
that makes anyone vote. Does not seem like we're going to get to 13. So we will bring this back to the next meeting. Thank you all for your participation today. I think we had a robust discussion about a lot of things. So at our next meeting, we'll complete the voting on the remaining code sets, which is 3. So that is exciting. And we'll hear presentations about non-claims-based spend. So that will also be exciting to move towards that. The recording and summary of this meeting will be posted on our website, and the next committee meeting is May 25th at 2:00 p.m. So thank you again, and I look forward to seeing you at the next meeting.
thanks, Judy.